Hi everyone, it's Dr. Nigel Giam here, the lead GP training program director for the St Mary's scheme and course director for Mentor MRCGP. I get a lot of STs often asking me about what case priming actually is, how to use it effectively in the SCA, and I thought it'd be very useful just to put together a quick video just to showcase an RCGP case around this. So if you want to forward your skills in the SCA after this video, please feel free to contact me. You can contact me through the website mentormededucation.com and also by email at mrcgpcourses@yahoo.com. So I've been a TPD now for coming up to about 18 years and been teaching for the MRCGP for well over 20. And one of the fundamental aspects that I see in people who fail this exam is they don't understand their place in the patient's story. And this essentially is what case priming is all about. Those 3 minutes that you have before the patient actually enters the room virtually are fundamental in actually showcasing how you use the information in context and knowing your place in the patient's journey. So, what is case priming? Essentially, case priming is knowing how to use that information in context. There are basically three aspects to it. And the first really lies with curiosity. It's like, why am I being given this information? Why am I being told, this patient's social circumstances, medications, blood test results, if there have been specialist letters, comorbidities, are they well controlled? Anything about their social circumstances. All the question is around why. The second aspect of case priming is then trying to map this to the SCA blueprint, which we're going to see in a second. And then the third is actually predicting the challenge that potentially might be coming in through the door. So if you're seeing a patient, for example, who's got a headache, have they had headaches before? Have they been treated? Have they been investigated? What's worked for them before? What hasn't worked for them before? And what's been discussed before? So always be curious. Why has this information been provided to me? We're going to talk about the blueprint when we have a look at the case, and then what we're going to start thinking about as a challenge. But it's so important not to go in blind because if you don't have a battle plan, what's going to happen is that the information that you want to elicit may have already been answered for you in the notes. So then questions become disorganized, unfocused, and not reactive to actually where we are in terms of the patient's narrative. So when we start looking at the clinical experience groups, we've got a patient less than 19, gender, reproductive and sexual health, long-term condition, older adults, mental health including drug dependency, urgent unscheduled care, health disadvantages including safeguarding, ethnicity, culture, diversity, inclusivity, new presentation of undifferentiated disease, prescribing, going through results, having a professional conversation and working through a dilemma. So let's have a look at this RCGP case again. So first level, why? I've got Mr. McLean. He was seen by one of the district nurses, but interestingly, the district nurse wasn't actually seeing him, but seeing his wife. Why is that? Okay, why is the district nurse seeing his wife? And we see that Mr. McLean isn't very well. He's had diarrhea. Again, we're asking why. Why has he had diarrhea? Examination findings, abdominal findings are actually quite reassuring. We have a slight postural drop. Everything seems to be okay, but he seems a little bit on the dry side. And we've been asked, to consult with Mr. McLean. So, Mr. McLean is no doubt expecting this phone call. So a clear passing candidate immediately wouldn't necessarily be going, how can I help Mr. McLean? They'd be saying, hi there, Mr. McLean, it's Dr. Giam. We're expecting this phone call. Okay, that's good because I can see that our district nurse saw you today about this diarrhea. Now, when we have a look at Mr. McLean's notes, again, all the time we're asking why. We've got diabetes, essential hypertension. He's on the carers register, so wife has dementia. So that's really important. Is anybody else there to support Mr. McLean? Does he have any other family around? He's on medications. Is he taking them? You know. He's doing well from a previous clinic review 3 months ago. But what's really interesting is we've got this blood pressure today, 146 over 82, which is significantly different from the blood pressure that was taken by the district nurse. So this blood pressure 3 months ago, significant postural drop compared to today. In terms of blood test results, diabetes control is adequate. What is interesting is we've been told he's got CKD stage 3. Again, very important. And the plan was to continue medication. So is he still doing so? So when we start thinking about the SCA blueprint here, then we've got new presentation of undifferentiated disease. We've got diarrhea. And when we start thinking about that, we need to start thinking, well, is this serious or not serious? And if it's serious, how serious is it? Is his kidney function now potentially got so bad? Is he so dehydrated that he might require to be seen today? Or maybe, actually, because the examination findings are relatively okay, he may not need to be seen again today, but we do need to organize some urgent blood tests. So 9 and 6 always go hand in hand together. Okay, you're always going to be assessed on some form of reactive risk management. We've got a patient in CKD stage 3. We have him on 2 medications that potentially can cause AKI. So prescribing's going to come into this in addition to, the older adult and long-term conditions. But the priority of this case will definitely be 9, 6, and 10. So if we have a look at the RCGP feedback around this case, they talk about the difference in blood pressure readings. They talk about this aspect of AKI. We don't know what's causing the diarrhea, so it's so important to elicit a patient's ICE around this very early on. Does he need to be further examined? Well, he had a pretty thorough examination, to be fair, but does he need to have further investigations? And the answer to that is probably yes, and they probably need to be done sooner rather than later. But the issue, I suppose, is that he probably won't want to leave his wife because she's got dementia and maybe he can't come to the practice. If that's the case, how do we work through that dilemma? Potentially we could get our district nurse to see him to do those blood tests. They talk about medication, they talk about the patient's priorities, they talk about the social situation. So the purpose of the case was to assess and safely manage an acute illness in a vulnerable patient with diabetes on whom his wife is dependent for care. So that's absolutely key, isn't it, in those 3 minutes? Are you recognizing that's what you're going to be assessed on? To recognize the medical risk, AKI, sick day rules, rehydration, and social situation in a man who probably will not want to be risk escalated. Now, if you want to watch how this is not supposed to be done, then do watch the case video of Steve McLean on the RCGP website, where the registrar unfortunately does not case prime, really goes in blind, doesn't know their place in the narrative, asks questions which are really not reactive to risk, and actually don't take into account the information that's already been provided. So you are going to be going in to the situation with Mr. McLean, thinking about actually how we negotiate risk escalation in somebody who probably does not want to be risk escalated. So case priming is key. If you don't have a good first half, you're not going to have a good second half. I'll be doing more videos on different aspects of behavioral indicators for the SCA, but Ola, who passed really, really well, if I could just draw your attention to the second email about case priming, being able to look at the notes, predict challenges just by looking at simple things. So again, just in summary, in conclusion, case priming involves 3 things. Why am I being given this information? Okay. Investigations, results, findings, previous discussions, medications, comorbidities, social circumstances. Second aspect, how might this map to the SCA blueprint? And third aspect, what is the potential challenges coming in through the door? Do consider joining us on the masterclass. Dates run every month. You can have a look on the website. Active participation is always advised first. If you want to get one-to-one feedback and score prediction, observer slots are available on selected dates. If you want one-to-one, then you can certainly email me. But at the moment, I'll only take on new mentees if they've actually attended the masterclass, as our one-to-one service now is so heavily oversubscribed, unfortunately, because of the huge high resit rate. And if you want to have a look at high performing, high marking cases, do consider signing up to the Mentor SCA online consults. I hope you've enjoyed this video and look forward to doing the next one. Do stay in touch. My email is down below, and you can contact me on mrcgpcourses.com or through the website mentormededucation.com. Many thanks.
Hi there.
Hey Ben, how you doing?
Yeah, pretty good, thanks.
Good. So thank you for agreeing to doing this. What we're going to do is Steve McLean, showcasing to the audience how to maximize marks in the 3 domains. So hopefully we're going to showcase what it is to pass this. And then I'll hand over to Ben to explain a little bit about his narrative into this and how he and I know each other. So I'm going to set a timer up, Ben, for 12 minutes. You've seen the candidate briefing from before.
Yeah.
So let me just get that timer up. Okay. All right. So Catherine says, does it make it more difficult to negotiate when the patient says no when they don't want a blood test? Well, hold on to that thought, Catherine. Hold on to that thought. All right, so let's get this timer up. You've seen the candidate briefing. I'll put you onto the candidate's notes. All right, timer starting in three, two, one. Let's go.
Hello, is that Stephen?
Yeah, speaking. Hello.
Hi, Stephen. My name's Ben. I'm one of the GPs. Is it okay to call you Stephen?
Yeah, please do.
Lovely, good stuff. Stephen, I've got an email here from one of the district nurses who popped out to see your wife this morning, and she was a little bit concerned about your diarrhea.
Yeah, no, thanks so much for calling. Absolutely. I mean, she doesn't see me. She sees my wife. She's dressing a leg ulcer for her. But I mentioned this diarrhea I've had. I've had it for about 5 days now. It's
Hmm.
just absolutely knocked me out for six. I feel so washed out with it. And I was hoping to try something, but she said I'd better speak to a doctor first.
I'm with you. You know, you've done the right thing. So yeah, please tell me what were you thinking of trying?
Well, the thing is, I can't get out of the house because of my wife's dementia. I can't even leave her for 10 minutes. So I was digging around in the kitchen cupboard and I came across some Imodium, which I know my wife takes when her bowels are playing up. She's got a bit of IBS, and I thought, well, you know what? That might help me because I just keep running to the toilet. But when I showed it to the district nurse, she said, no, hold fire until you've spoken to the doctor.
Yeah, no, absolutely, and we can certainly talk about that. Stephen, so tell me, so what do you think's been has been the cause of your diarrhea?
It's definitely something I ate, doctor. I mean, I can only get out of the house when my daughter's around. She came down a week ago so I could catch a football match, but on the way home I had a burger and I wish I hadn't. I don't think it was cooked properly. That's definitely put my tummy out of sorts.
No, okay. Yeah, and you mentioned your daughter there. Do you see quite a bit of her?
Well, usually, I mean, she doesn't live with us, but she pops around about 3 or 4 times a week just to give me a bit of respite. Because the thing is, my wife, she'll only sit with me and my daughter, but the problem is she's away now, my daughter. She's on a business trip. She won't be
Hmm.
back for 5 days, so it's all been a bit challenging, really.
That is difficult, isn't it? Yeah. I mean, in do you have any sort of backup plans for when this could happen?
Not really. I mean, it's not really sort of happened before as such. I mean, I've got a lovely neighbour. He's been doing a bit of shopping for us, but he can't sit with my wife. She doesn't recognise him anymore. And then when my wife gets agitated, it's very distressing for everyone. It takes hours to calm her down, you see.
That's really difficult. No, it's great to have good neighbours. That's
Mm.
lovely. Um, you mentioned that it's difficult with your wife. I mean, how's the this all been impacting your ability to care for her and care for yourself?
I mean, I'm okay. It has been a little bit of a struggle, but I'm getting on all right. I think I can hold out till when my daughter gets back, really. But I was just hoping
Mhm.
the Imodium might shave a few days off. That's all.
I'm with you. I'm with you. Okay, we can certainly talk more about that. The district nurse is really helpful, and she when she saw you, she did some examination of your tummy,
Yeah,
it was really reassuring.
yeah,
And she also did your blood pressure.
yeah,
And yeah, so when it was when you were sitting and standing, and that was a little bit that dropped a little bit when you stood. And when we compared it to to your baseline blood pressure, that was a little bit lower. And also, she noticed that your mouth looked a little bit dry.
yeah.
How was it left with the district nurse?
Well, she said the blood pressure was in the normal range, but she said just because I'm feeling a bit washed out, one of the GPs will call you just to see if anything else needs to be done.
Hmm.
So,
Yeah, no, no, really sensible. Yeah, and so just sort of revisiting your symptoms there, Stephen. How's the diarrhea been today?
well, I've been about I think 2 or 3 times. I mean, it's less compared to yesterday. Yesterday I went about maybe 4 or 5. So I think
Hmm,
the urge to go is slowing down a little bit now.
okay. And have you had any vomiting?
Only once when I came back from the football match, and I've not vomited since.
Okay. And in that diarrhea, have you had any blood or mucus?
No, no,
No, you
nothing.
haven't. Okay. And just thinking about your fluid intake, how much have you been drinking?
On average, I usually drink about 4 to 5 coffee cups of water a day, like a mug of
Okay,
water.
okay.
4 to 5.
And your urine out, have you been passing urine regularly?
I mean, I have. I mean, probably not as much.
Hmm,
I'm still going. Yeah,
okay. And has there been any change in color?
maybe a bit darker.
Okay. And any burning or stinging when you
No,
fall?
no, nothing
No.
like that.
Okay. And just making sure we're not missing anything. When you stand, do you get dizzy at all?
I felt a little bit off my feet first couple of days. I mean, that
Mm.
really hasn't happened since for the last
Okay.
3 or 4 days now. But I'm just very cautious. I'm just taking everything a bit slower, you
Mhm,
know.
mhm. Yeah, no, very sensible. And just checking, I know that you've got three regular medications on your notes. Have you been taking them all?
Yeah, yeah. I mean, they were quite happy with me at the clinic a few months back. They're quite happy with my diabetes. They just said continue all the tablets. That's what I've been doing. I know how
Mm.
important it is to stay on top of all of that stuff.
Absolutely. No, you're doing really well. Look, Stephen, I think, from everything you've said, I agree with you that you have got a tummy bug, and and it could well be from the burger, but it's difficult to tell. But I just wanted to talk to you about the Imodium that you mentioned. The dilemma we have with Imodium is that it can really reduce the symptoms of diarrhea, but it can actually, unfortunately, it can lengthen the period of the illness. So we don't actually recommend taking Imodium, and particularly with someone who's got kidney problems as you do. So
Right.
yeah, I'm sorry that wouldn't be a good idea.
Okay, no worries. I mean, I just thought I'd pass it by you. That's all.
Yeah, no, absolutely. It's a good thought. There are some things that we can do, and I think I really wanted to talk about two of your medications, metformin and candesartan.
Mm.
And I think it would be a good idea to stop taking those just until 24 hours after your diarrhea is settled. Um,
Why is that then?
yeah, I mean, we call those the sick day rules because these medications are brilliant long-term management for your conditions, but they can make things worse in the short term, make you more dehydrated.
Okay. Okay, all right. I mean, I can do that. I'll be safe for my diabetes, will it?
Yeah, it will. I mean, it's just for a few days. It won't cause any problems at all, and it'll actually keep you safe.
Okay. All right. Yeah, I can
Um,
do that.
yeah, good stuff. And just on hydration, I think it would be. You mentioned you're having 4 or 5 cups of water a day. I think we can increase that. I'd also really like it if you could um, get if we could give you some rehydration sachets. Would you be open to that?
Yeah, but I can't get out of the house. I can't get to the chemist. I don't have any of those
Um,
rehydration sachets or anything.
I'm with you. Okay. Yeah. I mean, do you think your lovely neighbour might be happy to pick them up for you?
Yeah, if he's around, I'll give him a shout. He's lovely. I mean, he will. I can give him if you send it to the chemist, if he's about, he can
Excellent.
pick it up. Yeah.
Yeah. No, that would be great. Okay. Well, we'll get this sent to the chemist for you. Um, just have one of those rehydration sachets every time you have a bowel movement, and then otherwise aim for sort of 9 to 10 cups of water a day anyway.
Okay.
And we really want to try and make that urine look more sort of straw colored and rather than dark.
Okay.
Um, the I think it would also be really important if we could get you to pop in today to the surgery so we could do some blood tests to
Oh,
check how your kidneys are doing.
I can't leave my wife. I can't leave her for 10 minutes, doctor. I mean, even when the district nurse came in, it took a good week and a bit for my wife to get used to it, and I can't leave her. I mean, I can come in when my daughter's back. I mean, she'll be back end of the week. Friday I could pop in.
Uh, yeah, I hear you. I mean, I know it sounds really difficult, but I think we need to get them done more urgently because we need to make sure that your kidneys are not being affected by this illness. Could I know you can't come to us, but would it be okay if we came to you and got one of our paramedic colleagues to pop in and see you this afternoon?
I don't mind. Yeah, I'm not going anywhere.
Excellent, excellent. Okay, we'll do that, and I'll keep an eye out for those blood tests tomorrow. And if there's anything that we need to do, I'll call you about that tomorrow.
Okay.
Um, you mentioned that you're caring for your wife and she has dementia. Have you had any formal support from the dementia support team?
No, no, just me and my daughter. We usually cope all right with it, but yeah, I mean, as I get older, and then you get situations like this, it
Yeah.
can be a bit more challenging, I suppose.
Yeah, I mean, would you be open to if I got the dementia support team to schedule an appointment to meet your wife and you and
Yeah, I don't mind when my daughter's back. Yeah, I
okay,
don't mind.
yeah, lovely. Let's do that. I think that there's probably lots of opportunity to help give you support and maybe give you some respite as well.
Okay, thank you.
I just want to make sure that things that over the next few days, I will keep an eye out for those. I'll keep an eye out for the blood test tomorrow. I'd like to schedule a telephone appointment with you in 3 days' time,
Yeah.
just to touch base and see how you're doing.
Okay.
If between now and then, if things go the other way, your diarrhea becomes, more significant again, worsens again. If you're not tolerating fluids, and if you're not peeing, I need you to contact us.
All right.
Is that
Okay. Yeah, I can
okay?
do that. Yeah, yeah, yeah. No problem at all.
Lovely. And yeah, we'll get the paramedic to pop out this afternoon, and I'll speak to you in 3 or 4 days.
All right, doctor. All right. Thank you. All right, let's stop there. So, a virtual round of applause for Ben putting himself out there in front of 60 plus people. Well done. Ben and I have been working on, I suppose, getting his battle plan together. Maybe you can share your story, Ben, because you were unsuccessful in the SCA
Yeah.
twice, which is
Yes.
surprising.
Yeah.
And you were
Yeah. So
close, right?
last.
In the
Yeah.
70s?
Yep. Yeah. I got 73 and a half the first time back last September. Passed mark was 77. And I hadn't really prepared. I set aside 2 weeks for it, and thought I had a decent chance, and then uh, rescheduled to take it again in January. And I think I had a false sense of that I'd been very close, and if I improved my clinical knowledge, I would be
Ah,
okay. The tell was that in January when I did it, I finished almost all the cases in about 8 or 9 minutes, and I passed the clinical management, but I totally bombed the data gathering. I just didn't data gather
yeah,
at all,
that's right.
and had a real just felt really low after that, and reached out to Nigel, and he's been building up my confidence, and I've
We
got
will
a
accept
game plan
no
now.
no lower than 85 in your reset, no lower. Otherwise, you're buying beers.
Okay.
And if you get
Yeah.
90
Yeah.
plus, then beers are on me for the rest of your life. What have you learned from the masterclass? Share with the audience what's changed now because you're battle ready and you want to be taking this at your peak and you're just about at your peak. What have you learned?
Um, every time I sort of work with you, I get more and more convinced about the need for following the story, um, and even if you can, even in 2 or 3 minutes of just the story, not getting taken into a symptom approach, um, you always see the benefit because the actors or the patients want to share the symptoms with you, but as long as you follow the story,
Yeah.
that's basically it.
Yeah, so the priming is something you and I have been working on. We're trying to play to strengths now, really get that data gathering really high, and that's going to obviously reflect really well in terms of both the clinical management and relating to others. Thank you so much, Ben. You can
Right.
switch your video off.
Thank
Thank you
you.
so much for putting yourself out there and just showcasing what a clear pass actually looks like in those three domains. I suppose if I was being really critical with Ben, his filler word, which tends to happen a little bit, is yeah, yeah, yeah. So we try and work obviously more on, I suppose, AEE in terms of that aspect of things. So when you look at this particular case, again, an RCGP case, you can see what is really important, the difference in blood pressure readings, the CKD stage 3. He's already been examined, so we were sharing those findings, but we do need an up-to-date um, kidney function test and EGFR, and that should be sooner rather than later. Sick day rules are applied. Obviously, the patient's priorities, he can't come for a blood test. He won't come for a blood test to the practice, so you've got to negotiate that. So the purpose of this case was to assess and safely manage an acute illness and vulnerable patient with diabetes on whom his wife is dependent for care. Risk, again, that word, AKI, the need to stop medication temporarily, self-care, including rehydration, and that social situation and priorities. So all of that was encompassed. So we teach three consultation mantras on the course. to keep you close to the top tips that we've talked about. The main is story symptom system, story starting in the patient's notes, opening up LISIF, using ICE to focus. AEE is the glue that holds everything together, using ICE to understand the situation and not over summarizing. Really, really important. And then readdressing the patient's agenda, sharing, and then getting into that swimming pool and committing to risk.